So I'm going to start giving you a sneak preview of the new national guidelines, and several of the speakers, Tracy, Mary, and Anita, had a big part in what you see. So let me do some definitions of terms first. So when you talk about guidelines, protocols, standards, and policy, that is directly related to the ultrasound study per se, or to the study that you are trying to put guidelines for. When you talk about certifications and credentialing and qualifications, this is pertaining to the personnel performing the ultrasound study. So, certification for sonographers, for physicians, the qualifications of physicians performing the ultrasound. And when you talk about accreditation, that is related to the ultrasound laboratory. That includes the facility, the equipment. So it includes both compliance with guidelines, includes certification, but also includes the laboratory, the environment that you're doing the study with. So some more definitions, guidelines. Again, these are statements that are systematically derived from a group of experts that is based on the evidence that exists for the day. Protocols is taking this information and putting it together in a framework to how you perform a study or what are the steps required in a specific, either an ultrasound study or a specific operation or treatment. Standards are when the consensus is high enough that you most likely will comply with those, and policy is a higher benchmark. Policy means that you will have to comply with the policy that exists for that particular study or disease and so forth. When you put these together, the burden of evidence is higher the more you go towards a policy. Certainly consistency in practice and need for compliance is more at that level. So when you talk about guidelines, these are recommendations based on experts' opinion, based on the evidence that exists at the day. They somehow become the standards in the United States when you put them together, especially related to ultrasound studies, but certainly they are not to the level of policy, they are not to the level of where you get to that level right here. Credentialing, again, is establishing the qualifications of professionals. This is typically done at commencement of employment or done during your employment with a preset requirement. So you can come in as a sonographer to a practice. It's required probably that within 3 years you will be ARDMS certified for a particular exam that you are doing. Accreditation, on the other hand, is a voluntary process that involves self-assessment. It's something that most of the time is voluntarily, especially related to OB/GYN ultrasound today, including fetal echo, and involves self-assessment by organization and peer review of various aspects of the practice. AIUM accreditation requires that you submit cases for peer review by other peers that are involved in the accreditation per se. There are two ways you can get accreditation in fetal echo, through the AIUM or through the IAC. I'm going to pass a little bit on the AIUM accreditation, but remember that accreditation involves the personnel with regards to what are their qualifications, training, and experience. With regards to how you do the study, do you follow the guidelines that exist? How do you document and store? And how that complies with your legal requirements in the state you practice? Do you have policies and procedures to safeguard patient safety, personnel equipment? Do you maintain your equipment on a regular basis with regards to making sure that it meets the standards and submission of case studies? The IAC is the other entity that provides fetal echo accreditation. This is an organization that came together from these programs right here, and they provide fetal echo accreditation. Primarily in the United States, the OB physicians tend to go towards the AIUM, and pediatric cardiology tend to go towards the IAC, but certainly there's overlap between the two. Here's the AIUM accreditation, which requires the physician qualification. Again, if you complete a fellowship program that includes fetal echo, you have to show a minimum of 50 fetal echo exams that you reported on and reviewed an additional 50, with 20 of those 100 abnormal cases. And there's a CME requirement, as you see here, and there's supervision and performance. If you have not done a fellowship, then you have to show evidence of 30 CME credits, and then you have to do a total of 100 cases, similarly 50 that are examination that you have done, perform, interpret, and reporting, and you can review an additional 50. And these have been around for a while. They have not changed. How many echoes are performed by MFM fellows in fellowship training is really hard to assess. There is no data today. As you probably know, the maternal fetal medicine fellowship just recently migrated into the ACGME. It was overseen by the board, and the ACGME is collecting now data with regards to these benchmarks. So I think it really becomes important to make sure that your fellows, if you are in practice, meet these qualifications, because if they go out and apply for AIUM accreditation fetal echo, you have to attest that they have done enough to meet these requirements. And then maintaining of competence, you have to do 25 exams per year, which is really not much. This is about 2 a month. With 2 being abnormal, you have to do 10 hours of CME credits every 3 years. When you submit cases to the AIUM accreditation, 1 case must be abnormal, and the other 3 cases could be normal fetal echo studies. Now, several years back, if you go back, we had an AIUM accreditation and guidelines, and we had guidelines by the American Society of Echocardiography. And there was a lot of discussion and push trying to come up with a single national guideline for the fetal echo study, because it really did not make sense to have 2 separate entities. There were a lot of issues with the AIUM guidelines. The issues with the ACE guidelines at the time, that it excluded a major segment of maternal fetal medicine physicians who were doing fetal echoes because they could not get credentialed through the process that existed. And it was quite a comprehensive study that is more than was commonly being done, and certainly was not a collaborative guideline at the time. More issues with the AIUM guidelines that exist in 2011, because it was really hard to differentiate what is a detailed ultrasound study and what is a fetal echo. Does the detailed ultrasound study looking at the LVOT and RVOT is enough? And then where is the difference between the two? Did not allow for comprehensive evaluation of the valves. Image retention was not specified, and certainly were not collaborative either. And this is Dr. Slansky and DeVore had an editorial in the Journal of Ultrasound and Medicine looking at various guidelines that existed. This is in 2011. And you could see that if you look at the AIUM guidelines then, did not require movie clips to be stored, did not require color flow as part of the fetal echo exam, did not look at morphology, where there were no biometry with regards to measuring the annulus of various valves, no pulse Doppler, and no M-mode. And you could see the difference between what existed at that time. So certainly where does the 76811 live, and where does the fetal echo live? Certainly we don't want to be here, mandating that we do sophisticated cardiac function on all patients coming for fetal echo without indication for such, and certainly we don't want to be here. We don't want to be doing just an LVOT and RVOT and calling this a fetal echo exam. So through a lot of work and collaboration from many of the speakers in this room, there was an important meeting that happened in 2010 that brought everybody together, and the decision was made that could we come together and come up with a single fetal echo guideline in the United States. And certainly I want to give a lot of credit to Mary to put a big group together at the time, similar to that, to come up, start working on a scientific statement from the American Heart Association that really kind of provided the basis for the most recent national echo guidelines that will be released soon. Because that included pediatric cardiologists and maternal fetal medicine specialists, and was very collaborative and was very comprehensive. So let me share with you where the 2019 fetal echo guidelines will be, and what are some of the requirements that you need to do as part of your study, and what are some that could be guided by indications depending on the referral for the patient. First, this was a very collaborative process. As you could see, the organizations that participated in this includes the AIUM, American College of Radiology, American College of OBGYN, American Society of Echocardiography, Fetal Heart Society that Mary will talk about and introduce to you, the International Society of Ultrasound and OBGYN. They have their own guidelines, but they were participating in this. They are in the initial process of revising their fetal echo guidelines. We're hoping that they will land very close to where we are. Society for Maternal Fetal Medicine and Society for Ultrasound, Radiologists and Ultrasound. So here's some of the indications. So they spend a lot of time trying to make sure the indications are evidence-based, and Anita led that team to put this together. So again, if you look at that list, some of the common ones: suspected cardiac structural anomaly, probably the most common referral to many of us. Somebody, basic obstetric ultrasound, they cannot see the heart or they suspect the heart is abnormal. Suspected abnormality in cardiac function, high drops, fetal tachycardia and bradycardia as defined here. Frequent episodes of persistently irregular cardiac rhythm. Major fetal extracardiac anomaly, and that has not been defined in detail, but any major malformation that exists in the fetus outside the heart. Nuchal translucency, spend a lot of time trying to figure out what the cutoffs are. Some of us use the greater or equal to 3.5, others use the 99th percentile, so we decided to have both in here as indications. And chromosomal abnormality by invasive testing or with cell-free DNA screening. And monochorionic twins. So these are the fetal indications. Now, there are some indications that kind of the evidence resides in the middle, is not as strong as the others. And the guidelines would state that it may be considered, fetal echo may be considered, if you have systemic venous anomalies, as you see right here, or greater than normal nuchal translucency measurement between 3 and 3.4. Now, on the maternal side, you have pregestational diabetes irrespective of hemoglobin A1C. If you diagnose gestational diabetes in the first or early second trimester, most commonly these patients were in a diabetic state during embryogenesis, so hence probably important to include them here. IVF is still here, including ICSI. PKU, if it's unknown status or if you have a level that is greater than 10, this is where there is substantial increased risk in congenital heart disease. Alloimmune disease with Sjogren's related to the SSA antibodies. The SSB antibodies do not really cause congenital heart block, so that has been taken out from prior indications. First degree relative of fetus with congenital heart disease. First or second degree relative with disease of Mendelian inheritance, with a history of childhood cardiac manifestation, retinoid exposure. We had initially significant retinoid exposure and had some recent discussion on that. That becomes a subjective assessment. I think you as a provider, you make a determination on that, and first trimester rubella infection. Fetal echo may be considered for the SSRIs. Here now, it was an indication before, now it's a little bit in between. Antihypertensive medications certainly to ACE inhibitors, autoimmune disease with SSA without the prior affected fetus. Again, first exposure to you, to the patient and to you, and second degree relative of fetus with congenital heart disease. Now, we added a segment that says that detailed ultrasound may be appropriate for those indications. So obesity, with a BMI greater or equal to 30. This is where you will probably do a 76811 rather than a fetal echo, because there is an increased risk of congenital heart disease, but certainly is not high enough to mandate a study. And you could see the list right here. And here's more on the maternal side with regards to the 76811 indications. So these are the indications for the new study. Now, this may change a little bit. Now, it's going out to the organizations for an up or down vote. So hopefully there will not be many changes. But if we have something that we have missed or surprising, then we would look at that. But I anticipate that there will not be much change. So what should you do as far as the study is concerned? Here are the grayscale imaging requirements that you need to do. So You can look through the list, 4-chamber view, and we will cover those during the next 2.5 days with regards to normal anatomy. 4-chamber view of pulmonary veins, LVOT, RVOT. Need to see the bifurcation of the pulmonary artery coming out of the right ventricle. The 3-vessel view kind of list of images. Certainly the 3-vessel view with and without the ductus, and the 3-vessel trachea view. The short axis views looking at the ventricles on short axis, low at the papillary muscles and higher up at the outflow tracts. Long axis view, if clinically relevant, aortic arch, ductal arch, SVC, and IVC. And then you have to get images with color and assess the following. So the IVC and SVC and ductus venosus, the pulmonary veins, at least 2, one on the right, one on the left, should be documented with color. Should document flow across the foramen ovale. Look at the AV valves with color. Look at the septum. Look at the semilunar valves with color, ductal arch, and aortic arch. Now, pulse Doppler is required for the right and left atrioventricular valves, the semilunar valves. You should Doppler at least 2 pulmonary veins, one on the right and one on the left, the ductus venosus, and then anything else that is driven by indications. Anything that needs to be Dopplered based on what you see on grayscale and or color Doppler. Cardiac biometry, you would need to measure the aortic and the pulmonary valves in systole, and you need to measure the tricuspid and the mitral valve in diastole. Again, these are requirements. And then what you need to obtain also are a bunch of video clips that you should save on your, it's not really sufficient to do a fetal echo and to save still images, because the quality of the review and the evaluation is very limited with still images of these key components. So you get a sweep from the stomach to the upper mediastinum, look at situs, including 4-chamber view and the outflow tracts with the 3-vessel and trachea view. Then you get a 2D and color Doppler at the level of the 4-chamber view, the LVOT, RVOT. Again, the upper axial planes in the chest, and the sagittal view of the aorta and ductal arches in 2D and color. Now, the guidelines will have diagrams like this to show what different planes you need to get. So you get the 4-chamber view, the LVOT, the RVOT, the 3-vessel view with and without the ductus, and the 3-vessel trachea view. And then here you see the aortic arch and ductal arches, and the sagittal views, superior and inferior vena cava coming together. And then short axis views of the heart, low and high, and the LVOT here. So let me just take you briefly through what you should do to comply with a fetal echocardiogram. So what I would recommend once these guidelines are out, to take that and revise your protocol for what should you include in the fetal echo and disseminate that to your sonographers and physicians. And I think you should include all these planes and images and clips as part of your fetal echo evaluation on a day-to-day basis. So 4-chamber view in grayscale, 4-chamber view in color, and spectral Doppler of the tricuspid and mitral valve, biometry of the tricuspid and mitral valve, looking at the ventricular septum, probably in a more perpendicular approach, and looking at the flow across the foramen ovale. So that's at the level of the 4-chamber view. The pulmonary veins, you should see at least 2, one on each side. Now with the newer technology, you can see 4 of them, as you see right here. And certainly with the newer modalities, you can see the whole branching of them. But you need to see at least 2, and you need to do Doppler, spectral Doppler of 1 on the right and 1 on the left. The LVOT in grayscale and in color Doppler. And you should get a spectral Doppler of the aorta, aortic valve, and a biometry of the aortic valve. The RVOT, again, in grayscale and color, and you should do the spectral Doppler and the biometry of that. And then you go into the upper chest. Here, you're going to get a view of the 3-vessel view showing the division of the pulmonary artery here into right and left pulmonary artery. And then the 3-vessel view used to be called ductal arch view. Had a long discussion about a month about this. And again, seeing the pulmonary artery, ductal arch, cross-section of the aorta, cross-section of the supravena cava. This is not a required view, the brachiocephalic vein or the aortic arch high up, but I put it for completion's sake, and the 3-vessel trachea view, showing the pulmonary artery, aorta, and the supravena cava here. Then the short axis view, I put 3 of them, but probably the one at the apex of the heart and one higher up towards the outflow tracts, or maybe this is towards the valve, maybe a little bit higher than that, maybe at the level of D here towards the outflow tracts. And then aortic arch without and with color. No requirement for Doppler here unless you suspect a problem. And the ductal arch without and with color. And then you get an IVC, SVC without and with color. In real time would be better, but I couldn't find one yesterday. So. And then certainly the ductus venosus is a requirement as part of the echo today. The umbilical artery is not. Many of us do the umbilical artery as part of the echo, but certainly could be done if there is an indication for that to be done. So these are the new guidelines that will be coming out. We're hoping in the next couple of months. There will be open access on the various societies' websites. I strongly recommend that you download the PDF and go through the list and create a protocol for you, share it with your sonographers and physicians to make sure that you comply with all the components of the fetal echo. Great. Well, thank you for your attention.